Okay, so welcome to this video on Streptococcus pneumoniae. So, let us begin. Streptococcus pneumoniae. So firstly, let us outline what Streptococcus pneumoniae is. It's a small bacterium. Because it has this coccus in its name here, Streptococcus, that implies that it is a little spherical bacterium. That's what coccus means. Anything with coccus, staphylococcus, streptococcus, enterococcus, it all means that the bacterium is a spherical shape. And this strepto bit implies that the way it grows in like chains. So when you look at it, when you gram stain it and look at it underneath a microscope, it looks like this. It's sort of grown in huge, long chains. And that's what streptococcus means. So anything with streptococcus in front of it means that it will look like this. It will be these huge, long chains of bacteria. So there are many different Streptococcus species. So Streptococcus pneumoniae is one of them. There's also viridans Streptococcus, Streptococcus pyogenes, and there's other ones as well. This is in contrast to Staphylococcus species, which Staphylos, I think, is Greek for grapes. So it grows and looks like bunches of grapes. So it looks more like this, huge, great bunches of bacterium in this sort of shape, rather than in this very distinctive chain shape. Okay, so if it grows in this way, it implies that the way it grows is it always grows along the same axis, so it divides along the same axis, so that you get these chains forming. So, okay, Streptococcus pneumoniae is also gram-positive, so it will appear blue when you gram stain it and look at it underneath a microscope. Okay, so Streptococcus pneumoniae, as the name implies, is a common cause of community-acquired pneumonia. However, it also is a cause of meningitis. However, in most people actually have this, are colonized by this bacterium in the nasopharynx. So if we just go over where the nasopharynx is, so if you have a nose here, then you have the nasal cavity here, and you have the the oral cavity somewhere down here, where that's the tongue, supposedly. And this bit back here is the nasopharynx. So it goes down like this, you go down like that, and the larynx then comes off here, and the esophagus goes down here. So this is the oral cavity here, here's the nasal cavity, so air comes through here. And this bit right at the back here, this is the nasopharynx. And this is the oral cavity here, this is the tongue, so this bit of the pharynx here is the oropharynx. And then further down where the larynx comes off, so you'll have the epiglottis somewhere here, this is the laryngopharynx. So most people have this bacterium, Streptococcus pneumoniae, colonizing their nasopharynx. And usually it doesn't cause a problem. However, if you are elderly or you're a child, any sort of condition that would weaken your immune system, so if you are immunosuppressed because of maybe you've had an organ transplant and you are on permanent immunosuppressants, or you have unfortunately acquired immunodeficiency syndrome, AIDS, and there are another sort of chemotherapies for leukemias and things like that are incredibly powerful at causing immunosuppression. So anything like that, and you are at risk of this colonization turning nasty. So most people have a colonization of this bacterium, Streptococcus pneumoniae, on the nasopharynx, and it does not cause a problem, usually. If your immune system is functioning healthy, it does not cause a problem. However, what can happen is that it can then migrate. It can migrate down from the nasopharynx into the oropharynx, then down into the laryngopharynx, and then through the epiglottis, down into the larynx, and then down into the trachea. So if we just move this up, so it'll go down into the trachea then next, So it goes into the trachea, and then so we'll revise the structure of the bronchial tree, which I went over in the tuberculosis video. So you have like here's the trachea. So coming on from here, really. Actually, I should draw it on from where I've drawn the trachea. So the larynx is here, and I'm not going to draw the larynx because I can't. And the trachea goes down like this, and it splits into the right bronchus and the left bronchus. And remember, the right bronchus is at a much much steeper angle to the left bronchus, around 45-degree angle. The right bronchus comes off, which is why if you swallow a bead or something and it goes down into your trachea, well, then you haven't swallowed it. Obviously, if you inhale a bead or something, it will most likely go down into the right bronchus rather than the left bronchus. So the right bronchus then branches off. So the first branch goes off to bring air to the upper lobe of the right lung. So you have an apical branch up here, you have an anterior branch, and you also have a posterior branch coming off that. So if we just quickly revise the structure of the lungs with this bit over here, you have two lungs. So here's the right lung, here's the left lung. Oh, I shouldn't have, it's got a sort of bit cut out where the heart's going to be, so the heart is here. And the right lung has a horizontal fissure rather, not transverse, and it has an oblique fissure coming down like that, and this one just has an oblique fissure coming down like that. So you have the upper lobe of the right lung here, the middle lobe of the right lung, and the lower lobe of the right lung here. And at the top here you have the upper lobe and the lower lobe, and this bit down here has a special name, so it sort of sticks out like that, and that's called the lingula. Okay, so that sort of features like the middle lobe of the right lung, and we'll see that on the left side there's a sort of like there is an equivalent branching to the lingula as the middle lobe has on this side. So this branch up here is supplying this lobe up here, this upper lobe of the right lung, and it splits into an apical bit supplying up here, an anterior bit and a posterior bit that sort of go off laterally. Okay, so then the right bronchus continues down and then gives off a branch like this, which splits into a lateral branch and a medial branch, and this supplies the middle lobe here. So this is the lateral bronchus, and this is the medial bronchus here. And then that comes off at the front, and this goes on down, and then the branch comes off around the back, and that's called the apical bronchus for the lower lobe. So we're now supplying this lobe, and then finally this splits into four branches: an anterior branch, a medial branch, a posterior branch that comes off behind, like that, and a lateral branch, and those all supply the lower lobe of the right lung. Similarly, on this side you have a branch coming off, which quickly bifurcates into two. One that's going to supply the lingula, which splits into a superior and an inferior branch, and that supplies the lingula. I know it's not really drawn as it would be, but it's a diagram. And then you have an apical branch, just like on this side. Then you have an apical branch, an anterior branch, and a posterior branch supplying the upper lobe. Then in the bottom bit, you once again have an apical branch coming off around the back, and then it splits into only three this time. It splits into an anterior and a posterior branch, and then it splits into a lateral branch. So you have a lateral bronchus, a anterior bronchus, and a posterior bronchus of the lower lobe of the left lung rather. So that's the bronchial tree. So what's going to happen is that the Streptococcus pneumoniae is going to go down from the nasopharynx to the oropharynx, into the laryngopharynx, then down the trachea, into the bronchi, and then into the alveoli. So when it gets into the alveoli, so I will now draw an alveolus. So we're on the histological level now. So alveoli, if you look down the microscope, they kind of look like this. They have these thin alveolar septa, and then they have the alveolar space. And in the alveolar septa, there are little blood vessels, the pulmonary capillaries here, which I'll just draw like that. And basically, so we've now got our Streptococcus pneumoniae in the alveolar space. So here it is. And once it gets in there, it's going to divide. And the way in which it resists, there are obviously big alveolar macrophages in here. So why doesn't the Streptococcus pneumoniae get phagocytosed by these bacteria? Why doesn't it get phagocytosed by these alveolar macrophages? Well, it has two tricks up its sleeve. Firstly, it has a anti-phagocytic capsule around it. So here is a capsule around the Streptococcus pneumoniae. So that means that the way this prevents it being phagocytosed, I found out, is that basically it prevents opsonization. So it prevents C3b, I think it is, binding to the surface of Streptococcus pneumoniae. It also prevents the binding of immunoglobulin molecules, so antibody molecules, and those are very key in opsonization process. So basically, certain molecules usually bind to the surface of bacterium, and these macrophages have complementary molecules which will bind to the molecule that has bound to the bacterium, and then once they have, they will then phagocytose the bacterium. But if you've got a capsule like this, those molecules that need to bind in order to make the bacterium more tasty for the macrophage, they can't bind, so it protects you against phagocytosis. So that is one mechanism they have. They also release something called pneumolysin. Now pneumolysin is basically a pore, so you have, it's basically, imagine just a little channel like this, and the Streptococcus pneumoniae releases the pneumolysin, and it goes and inserts itself into the membrane of the alveolar macrophages, and then water molecules move through the pneumolysin pore into the alveolar macrophage, and the alveolar macrophage swells effectively and bursts. And pneumolysin, that's one of the ways that the bacterium attack the alveolar macrophages. However, pneumolysin is very, very important also in the pathogenesis of this disease, because it's also going to go and insert itself into, so these alveolar septa are made up of little cells called type 1 pneumocytes. There will also be type 2 pneumocytes, which are much bigger and release surfactant, which is very important in breathing, in lung mechanics, preventing they prevent the alveoli collapsing, because it's similar to when you have like two sort of like microscope slides, two glass microscope slides, and you have water stuck between the two microscope slides, and you try and pull it apart, and you really, really struggle to move these two microscope slides apart. Basically, the alveoli are lined with water. Well, they're wet. So if you so you're at risk basically of these two getting close together, and they have the same problem that the test tubes have, so they get stuck together in the same way that those two microscope slides are stuck together because they've got the water between them. I've forgotten what the fancy name for it is, but it's effectively like that, and surfactant is preventing that from happening, so it means that you can actually breathe, that your alveoli remain open. So type 2 pneumocytes, the ones that release surfactant. Anyway, the Streptococcus pneumoniae, which has now colonized the alveolus, starts releasing this pneumolysin, which firstly attacks these macrophages, but it's also going to insert itself into the type 1 pneumocytes and the type 2 pneumocytes, and it basically causes them to swell. So water enters through the pneumolysin pore, the cell swells, and then bursts. And when it bursts, it releases ATP. Now, ATP will then go and activate pattern recognition receptors on the alveolar macrophages. And the alveolar macrophages will then be alerted to the problem. They will realise that there is something very, very wrong here. Cells are dying, basically. ATP should not be outside the cell. So as soon as ATP is outside of the cell, the alveolar macrophages know that there is something wrong. Cell death is happening. They have receptors for ATP, and these receptors then activate in the alveolar macrophage a molecule called NF-kappa B. So I should draw something about this. So if we have ATP being released from pneumocytes, so let's say these pneumocytes are dying, so they're bursting and they're releasing ATP. ATP will go and bind to pattern recognition receptors on the surface of the alveolar macrophage. So here we have an alveolar macrophage, say, and it will cause a cascade, a signaling cascade, which will activate a transcription factor called NF-kappa B. So in the middle here we'll have NF-kappa B. NF-kappa B. And NF-kappa B is then a transcription factor which will go to the nucleus of the alveolar macrophage and will activate the transcription of tumour necrosis factor alpha. So this starts spitting out tumour necrosis factor alpha. And tumour necrosis factor alpha then goes to the endothelial cells of the pulmonary capillaries. So let's draw this. So it goes to the endothelial cells of the pulmonary capillaries. And it basically causes them to contract. So the endothelial cells start contracting. They make spaces in between the cells, and basically it allows stuff in the blood plasma to leave the blood plasma. It doesn't allow cells to leave. The red blood cells cannot get through these holes, but fibrinogen is a very important component that leaves the blood, goes into the alveolar space, and basically is then converted into fibrin. So you get fibrin everywhere. So when you look under the microscope, you'll see huge red strands everywhere if it's stained with the right stain. I think it's Mason's trichrome they usually stain it with. And then the other thing which happens is that the endothelial cells put on a huge number of cell adhesion molecules, which bind to surface molecules on the surface of neutrophils, and neutrophils adhere to the side of the endothelium, and then they diapedese through. So they move. Basically, the endothelial cells have little gaps in between them. They're not completely confluent, and the neutrophil just sort of slides through the gap between the two cells, and it goes into the alveolus. So you form an inflammatory exudate, and you are now said to have pneumonia. Pneumonia means inflammation within the alveolar spaces, and this is specifically pneumococcal pneumonia. So pneumonia caused by pneumococci, which is another name for Streptococcus pneumoniae. So pneumococci is another name for Streptococcus pneumoniae. So you now have pneumonia, and that's extremely dangerous because it can reduce the gas exchange in the lungs, and if it reduces it enough, you are going to go into cardiogenic shock, where the cardiovascular system is failing, basically, to supply enough oxygen to your peripheral tissues, and that can kill you. But it's just a matter of which one dies first, the heart or the brain. Generally, it's going to be, of course, the brain, because the heart is receiving the blood first when it's still more oxygenated. That is pneumococcal pneumonia caused by Streptococcus pneumoniae. but there is another form of disease that Streptococcus pneumoniae can cause. But just before, so we're going to go back to the nasopharynx, and I just want to mention something that I forgot to mention earlier, which is how Streptococcus pneumoniae can successfully colonize the nasopharynx. Basically, the little bacterium, if we draw the bacterium here, how does it successfully colonize the nasopharynx? What defenses are in the nasopharynx to try and stop the bacterium colonizing it? And how does Streptococcus pneumoniae get around these? Well, firstly, to colonize the nasopharynx, if we have the nasopharynx here, the Streptococcus pneumoniae needs to be able to hold on. And to do this, it has a number of adhesins, which sort of are huge sticks, basically, of protein, which basically it can stick into the cells of the nasopharyngeal surface, and basically they're sort of like they're little hooks, effectively. They attach this bacterium to the nasopharynx and allow it to stick there. So these are called adhesins. And there are lots of different types of adhesins. Okay, so the other thing is that the nasopharynx, along with many epithelia, secretes IgA. Now, IgA is a specific type of immunoglobulin that is usually secreted from epithelia, and it often dimerizes, so you often see it drawn like this, but remember that that is not the characteristic of it. IgA is characterized by its specific Fc region. It's not characterized by the fact that it is a dimer, it just often is a dimer. So that confused me for quite a long time. I thought that IgA just meant that it was dimerized like this, that it was an antibody dimerized, that was IgA, but in fact this is IgA, it's just a dimer of IgA. IgA is characterized by the fact that its Fc region is different from that of IgG or IgE or IgM or IgD, all the other forms of immunoglobulin. Okay, so IgA as a dimer is secreted onto this surface, and basically this is going to, well, firstly you do have the antiphagocytic capsule, which is going to provide some protection from this, but you need more protection. And the way that Streptococcus pneumoniae deals with this is it secretes an enzyme called an IgA protease, which basically goes and breaks this apart, cleaves it up, breaks it down, and that allows the Streptococcus pneumoniae to live quite happily in the nasopharynx without getting obliterated. Okay, so that's just something that I wanted to mention. Now let's do the pathogenesis of meningitis caused by Streptococcus pneumoniae. So the pharynx, if we talk about the pharynx is drained by veins which go into the internal jugular vein. So the bacterium can occasionally cross the pharyngeal epithelium, and then it can go into blood vessels, and then it can end up in the internal jugular vein. So if we draw the internal jugular vein here, so let's call this the internal jugular vein. Internal jugular vein. And then it will go down into and join with the subclavian vein. This is obviously the right side here that I'm drawing, and they go into they form the right brachiocephalic vein. They join with the left brachiocephalic vein, so we have the other internal jugular here and the left subclavian vein here, and then they join into the superior vena cava here. And the superior vena cava goes into the right atrium, which then pumps the blood into the right ventricle, which pumps the blood out into the pulmonary trunk. So that should come off here. And the pulmonary trunk splits into the two pulmonary arteries. The blood goes round the lung, comes back in through the four pulmonary veins into the left ventricle. Left atrium rather, and then into the left ventricle, and then the left ventricle pumps it out into the aorta. And then when it's in the aorta, it it goes into the aortic arch, and it then goes into the common carotid. So remember, the left common carotid comes off the second branch of the aortic arch, excluding the coronary arteries. The first branch is the brachiocephalic artery, which splits into the right common carotid and the right subclavian artery, and then obviously you have the left subclavian artery coming off last. And then these common carotids go up, and then they give off they split into the external carotids and the internal carotid arteries. So I'll get another piece of paper. So and the way that it's going to get into the meninges is usually through the middle meningeal artery. So the middle meningeal artery doesn't actually come off the internal carotid, it comes off the external carotid. So if we have the common carotid artery here, and it splits into the external carotid artery and the internal carotid artery, the external carotid artery then goes behind the ramus of the mandible. So if we have the mandible here, we have the condyle of the mandible, the coronoid process of the mandible, and then the rest of the mandible there with the teeth here. So some teeth here. And this then gives off the, let's draw it here, this is the internal maxillary artery, which comes between off this side of the medial aspect of the mandible, so the aspect not facing us, comes the internal pterygoid muscle, and up here comes off the external pterygoid muscle. So it goes between those, and it gives off the middle meningeal artery, which goes up through foramen spinosum into the cranium. And basically the Streptococcus pneumoniae is going to follow that path. It's going to go up into the meninges, it's going to go into the subarachnoid space, and basically it's going to make itself at home in the subarachnoid space. It's going to divide, and you're going to launch, it's going to release pneumolysin just like it did in the lung. It's going to cause cell death. It's going to release ATP, which is going to drive an immune response. You're going to get inflammation in the meninges, meningitis. It's generally fatal. If it isn't fatal, it's going to lead to compression of the brain, and it's going to leave severe neurological impairments generally. So that is how Streptococcus pneumoniae causes both pneumonia and meningitis, and it's quite a dangerous bacterium. Just before we go, I want to mention something about if you grow it on a blood agar plate, what it looks like, because this is a colony that generally you do have to be able to identify. So if you have a blood agar plate, which is a red plate basically, so it's a plate full of red blood cells, and you basically grow the bacterium on this plate of red blood cells, and the colony on this blood agar plate, it shows alpha hemolysis. So you get a ring around the central colony. So the colony looks kind of like this. It's like a fried egg colony, and the outer ring is sort of like a sort of browny colour that looks kind of like pooey colour, and it's basically what happens when it releases pneumolysin, and it causes alpha hemolysis of the red blood cells. It's not quite as dramatic as Streptococcus pyogenes, which causes the beta hemolysis, which is it's more dramatic. But it is pronounced. It's very, very similar to viridin Streptococcus. And the way that you can tell the difference between it and viridin Streptococcus, the colony of viridin Streptococcus, if I draw the colony of viridin Streptococcus here, looks basically exactly the same, except that the ring will be the same colour and pretty much the same size, but the central colonies are slightly different colours. In viridin Streptococcus, the central colony is sort of like a beigey colour, whereas in Streptococcus pneumoniae it's a much darker brown than the ring is. So that's the way you tell the difference between a colony of Streptococcus pneumoniae and viridin Streptococcus when grown on a blood agar plate. And the last thing I want to mention is that there is antibiotic resistance emerging in Streptococcus pneumoniae. Specifically, macrolide resistance is a big problem in Streptococcus pneumoniae. So, macrolide antibiotics such as erythromycin, clarithromycin, azithromycin, roxithromycin, they all work by basically, okay, so I'm going to have to draw a ribosome. So if we have a ribosome, a bacterial ribosome, it kind of looks like this. That's the 50S ribosomal subunit, and this is the 30S ribosomal subunit. And basically what happens is the mRNA comes in here, comes out this side, and at the same time you have 3 sites where so this is the A site, this is the P site, and this is the E site. So tRNAs come in here, and there's a tRNA also in here which has the polypeptide chain coming off here. And basically this tRNA will be complementary to the codon of the mRNA here, and this whole polypeptide chain will be transferred onto this one. The whole ribosome will move along so that this one will then go into this one, and another tRNA can come in. And basically the polypeptide chain gets gradually longer and comes out this hole up here, which is called the polypeptide export tunnel. And basically what happens is that, say this bit isn't here and you've got a much shorter polypeptide chain, so just up to here, macrolides come and bind over this polypeptide tunnel, polypeptide export tunnel. And basically once the polypeptide gets to the point where it needs to come out, basically, it gets blocked, it can't get out. So the whole process is blocked because the polypeptide just builds up inside the 50S ribosomal subunit and it can't get any longer. So that's the way macrolide antibiotics work. But Streptococcus pneumoniae has come up with a clever trick. It has started making an enzyme called mRNA. Oh goodness, what is it? I've forgotten what its name. I think it's like N-methyl RNA transferase. No, it's RNA N-methyl transferase, I think. But I think it's basically an enzyme which comes and puts a methyl group on an adenine group up here. So remember that the RNA, that the ribosomes are made up of RNA and protein. So there's a huge great lump of RNA up here somewhere, and there's an adenine residue up here somewhere, near where the macrolides bind. And basically Streptococcus pneumoniae has taken to making an enzyme which comes and adds a methyl group onto this adenine, specifically onto the, I think it's N7 of the adenine. And I think it's specifically adenine 2058 for, a vital piece of clinical knowledge there. And basically when you add that methyl group onto that adenine, the macrolides can no longer bind, this bacterium is now resistant to macrolide antibiotics, and this is a big problem. This really is happening, and this population is evolving to make more and more bacterium which have this resistance property to the macrolides. And it should be noted as well that this confers resistance to a whole bunch of other antibiotics as well, because a lot of antibiotics bind near about the same site, and although their actions are slightly different from the macrolides, and this addition prevents them binding as well. So I think streptogramins are prevented by this property. I think also potentially, but it is a big problem basically, macrolide resistance in Streptococcus pneumoniae.